Good morning, one and all. Today's my lecture would be on the surgical management of mandibular impacted third molars. The learning objectives are you will be able to know the basic information on the surgical management of impacted third molars and summarize the theories, classification, methods to assess the difficulty in the third molar removal and the treatment, and of course the complications that occur during the wisdom tooth removal. My lecture outline would be on the theories of impaction, causes of impaction, indications and contraindications for removal of wisdom tooth, classifications on the different types of wisdom tooth, diagnostic aids, difficulty assessments, surgical techniques, and complications. The word impaction is derived from the Latin origin impactus. That is, when you say it is impacted, impact, that is, when an object or we can say it is a ball gets impacted onto the top of the roof. That is, it is like, in other words, a car gets collided on the a building wall. So that is called impacted. We can orient this with the our terminologies, dental part. So eruption of the tooth is impeded by a physical barrier or a mucosa via bone. We call it as impacted tooth. So cessation of eruption of the tooth caused by a physical barrier beyond the chronological age or ectopic position of the tooth. So impacted tooth is the tooth that has failed to erupt completely or partially to its exact position where it would reach in the dental arch beyond the eruption potential. The most common impacted tooth are mandibular third molar, maxillary third molar, maxillary canine, mandibular premolar, maxillary premolar, mandibular canine, maxillary central incisor, mandibular central incisor. Theories of impaction. As per Dabak, orthodontic theory, jaws develop in the downward and forward direction. So growth happens in the jaw, especially in the maxilla and mandible, the downward and forward, so that the tooth movements also occurs. Any change in the disturbance in the growth will affect the jaws, thereby the teeth. So a dense bone decreases the movement of the teeth in the forward direction. Phylogenetic theory. Nature tries to eliminate what it was used, and our civilization, as per history, humans and nomadic humans would have had a large jaws, powerful jaws to clench the flesh, okay, because they are animal eaters. But as the size of the jaws became decreased, as we can see, vegetarians are restricted to soft diet. So will lead to third molar impaction. Next is Mendelian theory. Heredity as a transmission from the small jaws of one parent to the large teeth from the other parent. Most importantly, being an etiological factor. Then pathological theory, any infections will correspond to the condensation of osteos or osseous tissue, leading to cease in the growth of the jaws. Hormones, to their part, either increase or decrease in growth hormones would affect the development of jaws. Coming to the local causes of impaction. Local causes: obstruction for eruption, lack of space, ankylosis of primary or permanent teeth, non-absorbing or over-retained tooth, non-absorbing alveolar bone, ectopic position of the tooth bud, dilaceration of roots, soft tissue or bony lesions, habits. Systemic causes would be prenatal, mostly prenatal like heredity, postnatal tuberculosis, anemia, malnutrition, rickets, osteoporosis, and cleft palate. Indications for removal of the impacted tooth: ovate infections, pericoronitis or pericoronal inflammation. Removal of the impacted tooth is considered especially when there have been one or more episodes or recurrent pericoronitis. That is the absolute indication for removal of the wisdom tooth. So it counts to about 75 to 80%. Then other causes would be unrestorable caries, periodontal diseases related to pathology, orthodontic reasons, and for need of orthodontic surgery. Prophylactic removal, again, it is a controversial one. Third molar in line of fracture, prosthetic reasons, and for need of autogenous transplantation to a first molar socket. Contraindications, as suggested by Larry and Peterson, the primary factors: age, extremities of age, poor health, surgical damage to adjacent structures, local factors, radiotherapy, teeth in close proximity to aggressive tumor, systemic factors, uncontrolled diabetes, pregnancy, underlying bleeding disorders, acute blood dyscrasis, cardiac conditions, patient and anticoagulant steroids. Clinical features: such pericoronitis, the patients would complain of a tenderness or radiating pain, especially to the ear, to the throat, to the floor of the mouth. The patient will also have a swelling on the cheek in the region, the angle of the jaw, and the submandibular region, or on the posterior region, along with a lymph node palpable. The swelling will be tender to touch, and upon inspection, when we are asked to open the mouth intraorally, we can able to see inflammation or swelling surrounding the tooth, which is to be erupted, especially the third molar. That it will be inflamed, markedly red, swollen, or suppurative lesion. In advanced cases, we can able to see trismus or restricted mouth opening. Thereby, it will lead to toxic systemic complications like a fever, leukocytosis, malaise, armamentarium. For the removal of the wisdom tooth, and the two for a surgical management, we need the following instruments, right from diagnosis to the removal of the tooth. Surgical management: mouth mirror, explorer, tweezer, BP blade, and BP handle, elevator, curette, extraction forceps, elevators, especially Copeland elevator, a Warwick James, straight, curved, then cryo elevator, mallet, chisel, and a suction tip. Whether we do with the handpiece or burr for bone removal, we need the appropriate instruments. Handpiece or chisel. Chisel, we need mallet, and for handpiece, we need a 702 or 703 burr, followed by a handpiece, a micromotor, kit, suction, and suction tube, and a irrigation would be normal saline in a kidney tray. Wound toileting can be done either a Rexidin oral rinse or a betadine gargle mixed with the saline. Suture can be done using a 30 Vicryl or 30 silk, whichever is available, along with sometimes any bleeding, we can have a gel foam. Otherwise, a simple toilet will do, toileting and then suturing. For that, we need needle holder, scissors. Third molar has been the most widely discussed tooth in the dental literature and the debatable question: to extract or not to extract. Accessibility significantly influences the degree of difficulty encountered during the removal of a third molar. The ease with which the tooth can be extracted depends on the degree of surgical exposure, creation of a pathway for tooth delivery, the ability to gain purchase. Based on the nature of the overlying tissue impaction or bony impaction, we classify for our convenience. Winter's classification, Bell and Gregory classification, Kellyan classification. So based on the nature of the overlying tissue, soft tissue impaction, if only the fibrous cover is there, we call it a hard tissue impaction. If there it is submerged into the bone, Winter classified satisfactorily based on the long axis of the second molar, like a vertical, a horizontal, inverted, mesioangular, distangular, buccoversion, linguoversion, tarsioversion. Bell and Gregory, he gave his classification depending upon the space available between the second molars, either horizontal and a vertical one. So class 1 means sufficient space available between the ramus, anterior border of ramus, and the distal side of the second molar. Class 2 is insufficient space available between the anterior border of ramus and the distal side of the second molar. Class 3 is no space available between the ramus and the second molar. Position. With respect to the depth, position A literally mean the position of the tooth is on level with the occlusal plane. Position B denotes it is below the occlusal plane but above the cervical line of second molar. Position C literally means it is below the cervical line of the second molar. Kellyan K, he classified based on angulation and position, based on the state of eruption, completely, partially, unerupted, based on the roots, number of roots, fused, 2 roots or multiple roots, root pattern, surgically favorable, surgically unfavorable. How to assess the wisdom tooth or as impacted third molar? Easier one and cheaper one easily available will be IOP, intraoral periapical radiograph. We can have a good assess on the angulation and the linear distance between the second molar and third molar. OPG, orthopentamogram, also be used. 3-dimensional access is given by cone beam CT. So ideally, IOPA gives a better clinical picture. Anterior edge of the film should correspond to the mesial surface of the first molar, and the superior edge should be marginally above the occlusal plane of the mandibular tooth. The buccal and lingual cusps of the erupted second molar must be superimposed. Relationship of the impacted tooth to the inferior alveolar canal should be appreciated. This is on the OPG where we can very well appreciate the level of the impacted tooth. This is a CBCT giving a 3-dimensional picture, especially close proximity to the vascular canals can be appreciated. Coming to the relationship of the impacted tooth to the inferior alveolar canal, on looking at a OPG or a IOPA, we can relate to the canal of the tooth apex. If the radiopaque lines are intact as they cross the impact tooth, it is said to be superimposed and separate. In case of perforation between the lines are interrupted, reduced radio opacity across the road. If it is grooved, the radiolucency across the road coincides with the outline of the mandibular canal. These are the 7 changes given by root and serve. Related to the changes in the roots as the darkening of root, narrowing of root, dark and rigid apex of the root, deflection of the root. And related to the changes in the canal are interruption of the white lines of the canal, narrowing of canal, diversion of canal. The difficulty assessment and removal of impacted tooth has to be planned priorly. For that, we have got difficulty assessments. It is the war line. The position and the depth of the wisdom tooth within the mandible was determined by the lines, the imaginary lines, white line, amber line, and red line. It is the imaginary line. White line is the imaginary line drawn along the occlusal surface of the mandibular molars, extended posteriorly over the third molar region. It gives the idea about the depth of impaction. Amber line. It is the imaginary line drawn from the surface of the bone on the distal aspect of the third molar to the crest of the interdental septum between the first and the second molars. So this line represents the margin of the alveolar bone covering the third molar. This indicates the amount of bone that has to be removed. Red line. It is an imaginary line drawn perpendicular from the amber line to an imaginary point of application of the elevator. Usually this line is the CE junction on the mesial surface of the impacted tooth. So if the red line is less than 5 millimeter, then extraction would be easier. If it is greater than 9 millimeter, then we have to do the surgery under GA, telling it is a difficult one. So assessment of difficulty is the fundamental in forming the optimal treatment plan in diagnosing or minimizing the complications. So compilation of both clinical and radiological information is necessary to make an intelligent estimate of the time required to remove a tooth. To assess the difficulty of the third molar, there are various indices described by authors like Warlines, Peterson Difficulty Index. So it simulates or summarizes the special relationship like as per scale, mesioangular. It gives the quantitative values as per the angulation, depth, ramus, and accordingly it summarizes the result as very difficult if it is going to be 7 to 10, and moderately difficult if the score is going to be 5 to 7, and it is minimal difficult if it is within 4. Wow, he gave his assessment criteria by analyzing the 6 factors: Winter's classification, height of the mandible, angulation of the third molar, root shape and morphology, follicle development, path of exist of the tooth, and the total scoring is related to the difficulties of the impacted tooth. Okay, what make your surgery is very less time. If it is going to be mesial angular class 1 position A, and better if it is going to be a soft tissue impaction, fused conical roots, and a root are not formed or within the 2 by 3 in young patient, large follicle and more elastic in young patient, then you will say you will remove it within 15 minutes. What make the surgery more difficult? If it is going to be a distangular class 3 position C, long roots, divergent roots, a narrow pedial, thin follicle, dense in an elastic bone like adults and aged people, and it is had a close contact with the second molar. In other words, we can say it is a completely bony impaction. Patient factors predicting increased difficulty of impacted removal. The other factors, contributing factors, would be obesity, dense bone, large tongue, strong gag reflex, position of a canal, infoalveolar canal, advanced age, superiorly positioned maxillary third molar, then apical root lower third molar in cortical bone, uneven anesthetic, atrophic mandible, limited surgical access. So, what are the surgical steps we should follow? First of all, we should have a good exposure or adequate access. Okay, so better we then flap design is a must. Okay, then amount of bone removal we have to design whether we are going for sectioning of the tooth or removal of the tooth in total. Okay, then elevation from the alveolar process, wound debridement, and suture. So coming to the first one, Exposure. There are various flaps designs given by various authors. The first one would be the Watson incision. This is the standard one used for the removal of erupted tooth. It has got a three parts: anterior, intermediate, and distal one. Anterior, it extends up to the gingival margin of a distal buccal to the second molar sulcus. Can be avoided by making anterior part more oblique. Sometimes you may encounter venous plexus. Intermediate is along the gingiva, and distally it should be placed laterally towards the ascending ramus. Modified warts. It is indicated for deep impacted molars. The anterior part should commence from the distobuccal of first molar instead of second molar like warts, not like warts. Large mucoperiosteal flap can be elevated, extends vertically downwards, and curves anteriorly, followed by gingival clavicular incision along the second molar. Distally, it is similar to warts incision. L-shaped flap. The anterior extension of the flap is up to the vestibule of the second molar, and may even you can extend up to the first molar. Exposure restricted only for buccal approach. The disadvantage is risk of damaging the facial vessels. So vertical relieving incision may differentiate itself from Watts incision. Envelope flap extends from the mesial papilla of first molar around the necks of the tooth to the distobuccal line angle of the second molar, then extends posteriorly and laterally up to the anterior border of mandible. It should not continue posteriorly in a straight line because the mandible diverges laterally. Easier to close and best healing. Comma-shaped flap gives a larger access, indicated for deep horizontal impaction. Periodontal pocketing, distal to second molar, is absolutely less. Grew and Moore flaps in 1970. Three design, one related to involvement of gingival margin of second molar, two flaps that did not involve the gingival margin of second molar. So produced an apparent decrease in the pocketing of distal to second molars. Bergwick's, it is almost like a tongue flap. So it extends up to the buccal shelf of the mandible. Incision line does not lie over the bony defects created by the removal of the impacted tooth. It's based at the distolingual aspect of the second molar. So sectioning of the tooth. When you decide whether to section the tooth or not, the criteria for sectioning are angulation of the tooth, unfavorable root pattern to protect the important structures. So advantages would be bone removal is eliminated. So less pain and swelling post-operatively, less chance of damaging to the adjacent teeth, reduced risk of bone fracture. Injury to the inferior alveolar nerve is considerably reduced. Operating time is also shorter. The disadvantages would be inconvenient to patient when splitting is done under local anesthesia. Teeth in elderly patients are difficult to spread and difficult to control the line of splitting. So recommended armamentarium are either with the burr 702 or 703 and with the handpiece. Otherwise, chisel mallets. So sectioning can be done based on the line drawn from the mesiolingual cusp till the distal root, and keeping it as a radius, an arc is drawn from the center on the IOPA, and if it touches the second molar itself, then we have to section the tooth. This is called arc of Lewis. Coming to the surgical management, surgical aspect of the removal of impacted third molars. We got two approaches: buccal approach, lingual approach. Buccal approach are given by Moore and Gilby, collar technique, lateral trephination technique. Lingual approach given by lingual split bone technique like Boulder and Henry. Modified distolingual bone splitting technique. So which one will you prefer, chisel or burr? Chisel and mallet is a conservative or a older procedure that was done in ancient days, in olden days when dentistry was begun. But nowadays we turn upon burr very easily. We can do it, okay, with the handpiece, with the machine. We can remove the root, remove the crown, split it. The advantage on the burr will be relatively easier, but the post-operative swelling would be more in burr compared to chisel. But sometimes chisel is not, but sometimes chisel and mallet is avoided in the patient is very apprehensive. Moore and Gilbert's collar technique, that is buccal guttering technique. This is a conventional one. With the help of a rosette burr 3, you have to gutter along the buccal side and also on the distal aspect of the tooth, like a C-shaped channel. Point of elevation is created with the burr. Amount of bone is sacrificed will be very minimal. Can be used in old patients also. Convenient for the patients. So this is how the tooth is buccal guttering done. Tooth is split into two and removed and suturing was done. Lateral trepanation technique. This procedure was given by Boulder and Henry to remove and partially form an unerupted third molar in the age group of 9 to 16 years. Modified SFB incision is made from the retromolar fossa across the external oblique ridge. It then curves down along the reflection of the mucous membrane above the vestibule, extending up to the first molar anteriorly. Such an incision leaves behind a 5 mm cuff of attached mucosa at the distal buccal region of the second molar. Mucobasal flap is elevated and buccal cortical plate is trephined over the third molar crypt. The same burr can be used to make the vertical cuts anteriorly and posteriorly. A chisel or osteotomy is applied in a vertical direction over the burrs. Then the buccal plate is osteotomized out, exposing the third molar crypt completely. So elevator can be used to deliver the tooth out of the crypt. Any follicular remnant present in the crypt should be carefully scooped out with the help of a curette, avoiding injury to the inferior alveolar canal bundle vessels present at the lower part of the crypt usually. So the advantages could be partially formed unerupted third molar can be removed, can be performed under general anesthesia, regional anesthesia, or also in a local anesthesia. Post-op pain would be minimal. Bone healing is excellent, and there is no loss of alveolar bone around the second molar. Disadvantages: virtually every patient has some post-operative buccal swelling for 2 to 3 days after surgery. Lingual split bone technique given by Kelsey Fry. Lingual splitting was introduced by Kelsey Fry, described in detail by James, lateral by Ward, and Davis et al. Modified and gave the listolingual splitting technique. So here, what is the landmark in this technique is that a vertical stop cut to be done on the anterior end on the buccal side and a horizontal cut just above the lower cut on the end of a stop cut should be done. And on the distolingual bone, it is side, it is carefully elevated, identified and fractured with the chisel at an angle of 45 degrees parallel to the external oblique ridge. Then tooth is elevated gently and the lingual plate fractured is grasped by the hemostat and it is placed at that level and sutured back after toileting. Care must be taken that the cutting edge of the chisel is not held parallel to the internal oblique ridge, as This may lead to the extension of the lingual split to the product process. A sharp pointed fine bladed straight elevator is then applied to displace the tooth upward and backward out of its socket. As the tooth moves backward, the fractional lingual plate is displaced from the path of the molar withdrawal, thus facilitating the delivery of the tooth. As the tooth has been removed from its socket, the lingual plate is grasped in fine humerus and the soft tissues are freed from it by blunt dissection. The fractured lingual plate is then lifted from the wood, thus completing the saucerization of the bone cavity. Advantage would be faster tooth removal, less risk of damage to the inferior nerve, reduces the size of residual blood clot by means of saucerization of the socket, decrease the risk of damage to the periodontium to the second molar, decrease the risk of socket healing problems. Drawbacks would be risk of damage to the lingual nerve. The lingual nerve and the inferior nerve damage has been reported to 1 to 6%. Increased risk of post-operative infection. Patient discomfort due to the use of a chisel and mallet for lingual bone removal and or fracturing. Only suitable for young adults, that too with elastic bone. Modified distolingual bone splitting technique. Davis technique. He mentioned not to separate the mucoperiosteum from the lingual area of the bone. The bone was released in segments to allow the tactile control of osteotomy to prevent penetration of the osteotomy into the soft tissue. More than one osteotomy per impaction was usually used to ensure the sharp cutting edge. Wedging the osteotomy between the tooth and the bone should be avoided to prevent fracture of mandible. Levy, he designed it, modified it by minimizing the periosteal reflection and buccal bone removal and by preserving the fracture of lingual plate. He claimed that these modifications reduce the possibility of lingual nerve damage, minimize periodontal pocket formation, and improve the chances of primary wound healings. Of course, by now we are known what is impaction and what are impacted tooth mean, what are the theories of impaction, and what are the causes, local causes, systemic causes, and indications and contraindications for removal of wisdom tooth, and then theories of impaction, classifications of different types given by different authors, then assessments of difficulty status. Coming to the complications, intraoperative complications. During incision, injury to the facial artery, injury to the lingual nerve, hemorrhage can occur. During bone removal, damage to the second molar, slipping of burr into the soft tissue and cause injury, extraoral or mucosal burn, fracture of the mandible while using a chisel and mallet, subcutaneous emphysema, or even tooth dislodgement. So if there is an accidental displacement, we have to have a good visual access and we can immediately remove the fragment. And if it is closer to the vital structures or it is displaced to the mediastinum, and if it is not symptomatic, then clinical and radiological follow-up should be done. And if it is symptomatic and if it is in the favorable position and if the fragment size is going to be more than 5 millimeter, then we have to remove it either by intraoral or extraoral fragmentation. This is a CT showing displacement of the tooth on the medial aspect of the mandible into the submandibular and then going in the submandibular region. This is on the pterygomandibular space and it is retrieved. During elevation of the tooth removal, luxating of the neighboring tooth should not occur. The soft tissue injury might occur on slipping of elevator. Injury to the inferior nerve bundles might occur. Excessive force will lead to fracture of mandible. Forcing the tooth submandible, I have shown this. And a breakage of the instrument TMJ dislocation might occur. So immediate post-operative complications would be pain, swelling, trismus, prolonged anesthesia, bleeding, infection, nerve injuries. Delayed complications would be delayed healing, dry socket, and distal pocket to second molars. So post-operative pain and swelling can be managed by giving NSAIDs, that is non-steroidal anti-inflammatory drugs, analgesics, and when needed, we can add steroids to counter this. So the trauma is directly proportional and the amount of bone removal is also directly proportional to the post-operative pain and swelling. Trismus. might also occur when there is a repeated or trauma to the medial pterygoid muscles or prolonged duration of the procedure. So excessive stripping of the pterygomandibular raphe might land up in trismus. So regular jaw movements or mouth closing, opening exercises to be done for 1 to 2 days post-operatively, and the muscle relaxant could help the patients. Infection. If there is a pus discharge, we have to continue with the higher dose antibiotics, higher level. Then oral rinses can be accompanied like a Rexidine or a betadine goggle. Ask the patient to avoid smoking and other harmful habits. If the patient is diabetic or any systemic diseases, a good oral hygiene and a diabetic control should be checked. Patient on steroids and immunosuppressives should be checked the systemic status, and accordingly the infection should be controlled. Nerve injuries. Coming to the inferior alveolar nerve, the term temporary would be ranging from 0.4% to 8.4%. Permanent inferior nerve dysesthesia could occur from 0.4 to 2%. Coming to the lingual nerve, temporary lingual nerve palsy occurs from 0.2 to 23%. Permanent lingual nerve palsy accounts to about 0.04% to 0.6%. Dry socket is a clinical condition which is seen if few days after the extraction of the tooth. The dry socket is the absence of blood clot filled with the debris. Predisposing factors would be predominantly on females, smoking, advanced age, traumatic surgical procedures, presence of pre-existing peritonitis. Signs and symptoms would be moderate to severe pain on the third or fourth day after tooth removal. Throbbing pain may radiate to the ear. Swelling, foul odor and taste. Exposed bone would be tender. Fever followed by lymphadenopathy. The prevention would be copious saline irrigation during intraoperative phase involving bone cutting, perioperative use of mouth rinse, use of intra-alveolar medications placed on the socket like tetracycline, use of systematic antibiotics, maintain good oral hygiene, a traumatic surgical procedure. Management can be done with using intra-alveolar dressing like alveolar gel, systemic antibiotics. Distal pocket. If the tooth is close proximity to the second molar, while removing there will be bony bone loss followed by sensitivity be the predominant complaint from the patient. When we see there will be a pocket formation, foot lodgement, and thereby bone loss and infected. So we have to do a papilla preservation flap or bone substitutes or bone grafts can be done, and a good oral hygiene will slowly improve the bone loss and gives the patient a better healing, wound healing. The slow bone formation will be there for a period of 6 to 9 months. For that, we can do uh, other flaps, commercial flap or papilla preservation flap procedures. Thank you. These are my references.